Kia ora koutou, ko Superstar, taka wingoa. A very warm welcome to you all to this online presentation brought to you by Auckland Medical Research Foundation. My name is Sue Brewster, and I have the huge privilege of being the Executive Director of the Foundation, or AMRF as we are often called, and I've been in this role for over 7 years now. We were founded in 1955, and since that time we have awarded over $100 million worth of medical research funding. We're the largest independent funder of medical research in New Zealand across the spectrum of all diseases and disorders. And what people really love about us is that all of our operational costs are covered by an external benefactor. So every cent of every donation goes directly into the cause, funding world-class medical research. So one of the world-class medical researchers you're going to hear from very shortly is Professor Grant Searchfield, a leading audiologist and also a researcher in the specialist area of tinnitus, which he has been studying now for over 20 years. And we have funded him and his team to make some of the groundbreaking research you're going to hear about tonight. So Grant's accolades are many, and I'm actually going to have to read them out because the list of what he has done and what he is very long. So here we go. Professor Grant Searchfield is an audiologist and neuroscientist, and in 2001 became the inaugural director of the University of Auckland's Hearing and Tinnitus Clinic. He obtained his doctorate in audiology from the University of Auckland in 2004 and currently holds the position of head of audiology at the university. And from 2007 to 2015, he was on the scientific committee of the Tinnitus Research Initiative in Germany, and 2016 to 2022 on the Scientific Advisory Board of the American Tinnitus Association. He is the Deputy Head of the School of Population and Health Co-Director of the Ideals Moore Research Centre for Hearing and Balance, and founder and scientific director for True Silence, the organisation providing personalised tinnitus treatment, which is the breakthrough he will talk to us about. He is an international editorial associate for the Journal of the American Academy of Audiology and chief section editor, Tinnitus, Frontiers in Audiology. So he is an extremely talented and very busy man, and I am delighted to be able to bring you the latest in audiology and tinnitus research from Professor Grant Searchfield.
Thank you very much for that short introduction. So, inevitably, when you look at a person's research career, it's never about one person, is it? You know, it's always a number of contributors to that. And what I thought in this talk is, as much as I like to talk about myself, and I'm quite happy to share that as we go through the day, and I will eventually get to some of the work that I've focused on, I thought it would be of interest, particularly in the context of AMRF's support for tinnitus research, to tell you a little bit about New Zealand's standing in this particular space. And I've got a number of diagrams that look like this I'm going to show you, which look a little bit like someone has let a spider loose on some paint and they're skittered around the page. But what these show are the little lines are connections between, in this case, different universities or research establishments around the world. And the size of the circle represents their contribution to tinnitus research. So I'm going to show you a couple of those because I think it's really important to point out that the University of Auckland is on there and the University of Otago amongst all these universities in Europe and in the United States. Right? So there's one example, and these are from publications from 1980 through to the year 2020. Here's another one. Again, the spider has been crawling across the page, but again, I've highlighted in these universities, University of Auckland, University of Otago. That was from 2001 to 2020. And here we have a picture representing countries. This is not per capita, this is total contribution, right? There is no adjustment there for the population. So you can see that large countries like the People's Republic of China, the United States, and Germany are on there. But it's also nice to see that here we are, all right? New Zealand is well represented. The bubble is about the same size as France's potentially, right? So this is a really significant contribution. From the same publication, the University of Auckland, in which we are in today, was ranked 7th in the world for tinnitus treatment research. So this is something quite outstanding for a university group within New Zealand. My next part of the talk is to sort of describe how we got there. All right, there are a number of different aspects to that, including luck and imagination. All right, but also a big contributor has been the AMRF and also their contributors, such as yourselves. When I saw these diagrams, I was quite chuffed, as naturally you are, but I thought actually it would be very good for us to document what we have been doing in New Zealand. So just last week, this particular paper was published in the Journal of the Royal Society of New Zealand, and it examined all the research that New Zealanders had undertaken, either within New Zealand or New Zealanders as part of a research group, to scope out what is it that we are actually doing. Is there something particular that we're good at? What we found is that we research most things that we would normally categorise in and around a health problem. We've done work in epidemiology, so we have one of the largest studies in the world of population-related tinnitus statistics. We've done work in trying to create models which are really about trying to explain things in broad brushstroke thoughts. There has been work done in animals to understand what the causes of tinnitus are. That has been expanded in human-based mechanisms where we've done testing of people to see if we can explain why they have tinnitus. We've done work in developing new and innovative ways of assessing tinnitus, both in the form of questionnaires, but also in the way that we can measure brain activity. We've done some work in pharmacotherapy, so drugs for tinnitus. And this is an area where I think everyone would like progress. We've become very used to going to see our doctor and us explaining a particular symptom or problem, having an assessment, perhaps some blood tests, and then being prescribed a medication. And unfortunately for tinnitus, at present, there is no medication. So there has been work going into this particular area, but it is quite a bit of searching for a needle in the haystack. Neuromodulation is a way that we can change brain activity, either by using a magnet, and the magnet can change activity in the areas of the brain underlying where the magnet is, or electrical stimulation, very low level electrical stimulation. The stimulation is a little bit like the battery that you find in your smoke alarms. Sensory therapies, hearing aids, different sounds, training of the brain to try and train the brain to learn to push aside the tinnitus so it actually disappears from consciousness. And then we've done work in clinical practice. Now, this is representative of a whole of New Zealand approach, all right? And how did we get there? How did this come about? I'm going to focus mainly on my journey, but just to understand what I'm telling you is going to be replicated in different ways at other universities and with other individuals as well. So how do we get there, and what do we mean by this tinnitus breakthrough? Well, my first job as an audiologist was at Green Lane Hospital. This was a photo slightly earlier, but it does represent the hospital at that particular time. Some of you will possibly remember the prefab huts that were actually put up during the Second World War as part of the US military hospital, I believe. They were temporary. So in the early 1990s, I was still practicing audiology there. Now, both for my journey, I was lucky enough to work with ear, nose and throat specialist, some of you may know, Ron Goody. But he also is involved in some of the very first tinnitus research in New Zealand that actually got New Zealand on the research map. And that was work looking at an anaesthetic that, when given intravenously at a pain clinic to reduce pain, it was observed that that also reduced tinnitus. All right? So the people were there not for their tinnitus, they were there for their pain, but they took this drug and their tinnitus went. Unfortunately, that work done in 1977, 78, 79, thereabouts, was difficult to replicate in a way that was safe, that could be taken orally. You have to take an injection, and it was very short lasting, so it was never going to be an effective treatment. But I had the luck to be working in this space, and it happened that Ron learnt that I had an interest in tinnitus, and that was one of the some of the lubrication to get my wheels moving towards research. The other person who is in the back there, Professor Peter Thorne, who also was involved as a very young researcher at the time, I might add, Peter, in those early studies of the lignocaine. He was a mentor for me in my PhD. So this young live individual here is me doing my PhD with my book there, writing down some nonsensical findings. And they got me on the road, all right? But at that particular point, a couple of lucky things happened, all right? This is where the luck and being fortunate came about. Two things. The first was that the J.M. Cathy Trust developed a fund for tinnitus research, all right? That was great because I was one of the few researchers in New Zealand doing tinnitus. So my chances of getting my feet in the door as a young researcher were great, all right? My chances of actually getting funding, all right? So that's part of it. Another thing happened. This gentleman here, some of you may have seen him before. Dr. Matteo Denora is the founder chief of Team New Zealand. He's their international financial backer and facilitator. Now, why is he there? Because he has tinnitus. And it happened, he was in Auckland with Team New Zealand, trying to find out, is there anybody in New Zealand doing tinnitus research? And he also, through his own individual wealth contributed to getting our work underway, not only in Auckland, but also at the other centres through New Zealand. One aspect about his work that was also helpful, before I focus on the AMRF work, is connections. Because he had been doing this in every country around the world as a high flyer could do, visiting various medical centres, and he created the Tinnitus Research Initiative to fund research and to network researchers. So one of the characteristics of New Zealand research is we are very well connected, and we work together with other groups around the world. That has grown our expertise, but it has also enabled us to profit from those connections. What I'm going to focus on now is really the support that this particular trust and the AMRF have provided in my individual journey to where we actually are. It's not necessarily entirely correct in chronological order. It's one of those sort of things based on real life, all right? Because I can't remember exactly how some of these things came about in order, but I'm going to present it in what I think is a logical way. The first research was very much based on clinical experience, what I was doing, what I was seeing in the clinic, and thinking, this is an interesting question. Is there any evidence to support this? What can I do to find out about that? So a lot of that initial work was based around hearing aids. Hearing aids and hearing aids with sounds inbuilt to them so that the hearing aid would improve hearing, so reducing the reason for the brain to focus in on the ears, and the sound to compete with the tinnitus sound. And at the point that I began to get interested in this at Green Lane Hospital, there was also an international growth in tinnitus research occurring. And so we were able to come into that with novel pieces of research and help that growth. Now, along the way, as well as using hearing aids, because we don't have any inbuilt New Zealand industry here, all the hearing aid manufacturers are based overseas, we would jury rig hearing aids and connect them up to commercially available audio equipment. So some of you may remember iPods. All right, now we all use our phones for music, but these were something that really were not too expensive, were readily portable. And we would wire those into hearing aids, and this enabled us to essentially create all sorts of weird and wacky sounds that we thought might be able to help tinnitus and to be able to play that back via hearing aids. That research eventually found it into the hearing aid industry and was adopted by many hearing aid companies in terms of apps that they would have on their for their hearing aid use. Now, instead of the wires going to the hearing aids, we have systems where we have the sound on the phone, and then wireless, we can send that through to the hearing aids, and that can be used instead of headphones for listening to sounds. Now, initially we did this at what we could do sort of a level with student projects. We would go to manufacturers and we would ask, can we have some hearing aids? And we would be able to do that. But as we move forward, we become more reliant on either funding support to provide that technology, either through donors such as the AMRF or potentially through the companies themselves. So we've done a bit of both. We've done research for hearing aid companies and we've done our own independent research where we've been modifying things. This is just some research relatively recently. I think this was published beginning of last year for a hearing aid company called Oticon, which is based in Denmark. And what we did is some test of their latest tinnitus hearing aid and their software on the phone. And what we did was we compared new hearing aid users, those that never worn hearing aids, and how much they improved with these hearing aids that were provided for the first time, and individuals who were already hearing aid wearers, and we provided these new hearing aids. We used questionnaires to assess how well they were doing. This TFI here, Tinnitus Functional Index, is a gold standard for questionnaires internationally. And I had the privilege of being an author on the development of that particular questionnaire. What this chart shows is before and after having the hearing aids, and this shows a benefit amongst new hearing aid wearers, and also for those people that already had hearing aids, they also received benefits from having hearing aids fitted. This is from just another questionnaire showing the same pattern. Hearing aids help because they help address the disconnect that we have if we have a hearing loss from our environment. There's a wonderful study done in 1952, 1953 in New York, where a couple of researchers took young university students and put them in a soundproof room and gave them a piece of paper with a pen or a pencil and said, I want you to write down all the sounds that you hear. This was a soundproof room. There were no real audible sounds with that environment. Around 90% of them heard sounds. They heard hissing, buzzing, cicadas, high tension wire, all the sounds that are very familiar to people if they experience tinnitus, or myself hearing about that. So if we go into an incredibly silent environment and we're actively listening, we can hear the brain working. Right? There's always activity in the brain and we're hearing that. And we have a criteria for determining whether we hear something or not. If we're busy doing something else, focusing on talking to you here, I'm unaware of my tinnitus, all right? My concentration is on something else. When we fit hearing aids, we're altering that criteria and we're removing that soundproof room around people's hearing, and more sound can come in to actually activate the hearing system. Also, if we have good hearing, we're more likely to be socially engaged, listening, hearing the background sounds, whether that's rain in the distance, the sound of birds outside, whatever we might want to listen to. It helps us listen to those things we want to listen to rather than being listening to the tinnitus itself. Now, how do we study what is happening when a person has tinnitus as opposed to when they don't? Because if we are able to capture that, we can identify parts of the hearing system that are changing that might be responsible for creating the tinnitus. And if we understand that, that gives us targets for therapy. Those targets might be by brain stimulation, or they might be by a particular pill. We can do that by MRI scanning and looking at the effect of a person being measured with and without sound there. But one of the things that we do and is notable in New Zealand, we do this across the different tinnitus research labs, is we use electrical recordings of the brain. So here's an individual, they've got a cap on, and each one of those wires is measuring a particular activity from the brain. And what we are able to do is to create maps of brain activity. All right, and in this particular case, what you can see here is a group of people, averaged, for a short period after they're presented a loud sound where they don't hear tinnitus. So many people with tinnitus will hear it if you present a loud sound for a very brief period of time, usually just a minute or less, their tinnitus will disappear. So what we're able to do is to record the activity before, while the tinnitus is gone, and when it comes back. And that enables us to map the brain. All right, and it's quite a complicated process. As you can see, the brain is changing all the time. It's not like a photograph. It's not static. It's changing, and we have to average that and apply mathematics, or in this case, machine learning, artificial intelligence, to try and understand what we're seeing in that animation. This is a map of electrical activity. Each of the lines here represents a mathematical connection between one of those places we were recording from and another one. And if there's an increase in firing at the same time, then we see a blue line. If there's a decrease between different areas, there's a red line. All right? It shows us whether those parts of the brain are firing together or whether they're out of synchrony. And we're able to map that. These 3D maps are nice pictures, they're interesting, but they're quite difficult to actually interpret. So we can flatten it out, and that's what this square looks like. Now, in this particular study, we used sound, all right, like I was talking about, through the hearing aids to try and disrupt tinnitus. And we measured brain activity before and after treatment. And then we looked at those people that benefited from that treatment. Those are the responders, and those people that we provided the treatment, it didn't work. All right. And that's quite often the case. You know, it won't work for everyone. But what we can quite clearly see for those people that didn't respond, for those people that did respond, is particularly changes in the parietal occipital area of the brain that is involved in attention and pattern processing. It's usually associated with vision, which seems quite odd because it's actually a change in tinnitus. But these things we're learning are so interconnected and multifaceted that the idea that the brain is entirely broken up into visual, hearing and touch areas is no longer wholly true. So what does this mean? Oh, that's great. We've got a picture of the brain before and after. We're showing areas. We could target those areas as we learn more. One of the interesting things is that we can do these measurements. Person comes in, we can do the measurement, and then we can say, you're not going to benefit from this treatment because your brain activity resembles people in this group. Or you're a good candidate for this treatment because your brain activity represents this group before we do any treatment, all right? And this is particularly important when our treatments that we're looking do take months, all right? So a person is going to commit some time to these treatments. That's interesting, and we can do these predictions with around about 95 to 99% accuracy, which is really good, but it's still benefit, no benefit. What we want to be able to get to, and I'll talk about in a moment, is where we can see a person and in real time, the treatment will actually recognize that particular brain pattern means that this particular treatment is going to be best for you. Now, 10 minutes later, the next day, as you improve and your tinnitus changes, do we actually need to introduce a new treatment because the one that we're using has essentially reached its full potential? And this is where we are going in terms of personalised brain mechanism-based therapy. This is a picture of the brain, and these are all the studies up to, I think it was beginning of this year, that have been shown brain changes with therapy. Most of these are based on sound. So there are various areas there that show this change up. There are different regions responding to different therapies, but there is an important core region that is fairly consistent across studies, and that's shown in this diagram here. There are 4 parts of the brain that are heavily involved in tinnitus. The auditory network, that makes sense. People hear it as a sound. Okay, that's a fairly sensible thing. So there, we've got then the salience network. What's this about? This is how important is it for me to hear something and then react to it. If we think about hearing, we can consider it our survival sense. By that I mean it is our sense that tells us in 360 what is happening in our environment. We can hear around corners, we can't see around corners. If we hear something that is threatening to us, those of us here who have survived, well done, will react to it, right? If you don't react to things, you don't necessarily survive. One of the odd things about tinnitus, if you can consider this, is if you had a tribe and you were out in an environment, all right, where listening to sounds was really important and reacting to it, you'd want someone with tinnitus in your tribe because they would be the ones that react to those quiet, threatening sounds. They have a predisposition to pick out, identify, and then react, right? Right? You know those movies that, the documentaries that David Attenborough does, and they're the meerkats, and they pop their head up and they're always looking around, all right? That's going to be the tinnitus sufferer because they're always looking for something to attend to. It's totally subconscious, right? It's not like we go out there and attempt to do that, but it is a reflection of this particular part of the brain. It does tend to mean that people that experience tinnitus are often a little bit more anxious, all right? Not necessarily clinically anxious, but just a little bit, oh yes, I tend to react to things a little bit more, all right? So salience network, how important is it, all right? If I'm walking down the road and a siren goes past, I'm going to turn and look. I know what that is, I'm going to react to it, right? I hear tinnitus. That's something that I'm not familiar with, but I've got to find out more about it. And the central executive network that controls a lot of the tension that we play is an important controller. So people can be trained to hear their tinnitus more. Wouldn't want to do this, right? But if a person has tinnitus and you say to them, oh, you should check that every day to see how it's going, right? So every day they sit there and think, oh, is my tinnitus a 6 or a 7 today? I'm going to listen into it. I'm not quite sure. I'll check it half an hour later, right? They're training themselves to get better and better and better at hearing the tinnitus. So one of the things that we can do is actually alter that network, change that network. And that is about changing behaviours, changing learning. The default mode network is what our state is generally. If it's what we are acting at the moment, when we're not really doing everything at all right? And it's important because tinnitus becomes activated within our normal perception, our default status. So these are 4 regions of the brain, among others, that are important targets for treating. How are we going about that? Well, one of those things is about that training, actively training people not to listen to their tinnitus. This involves using auditory training, visual training, and sometimes tactile training, where what we're trying to do is get people better at not listening to their tinnitus. The easiest way of doing that is to get them better at hearing other sounds and focusing externally rather than focusing internally. This is not something that can be done just by willpower. I'm not going to hear my tinnitus. No, I'm not going to hear it. I'm not paying attention. I'm not going to do it. That's not the way this works. This is not about willpower. It's not about vulnerability in the individual. It's about how we learn. So in the games, we reward people for not listening to their tinnitus, and effectively we punish in a nice way, all right? We punish for listening, attending to the tinnitus. Essentially, we don't reward people for that, all right? And so when people use these training games for 3 weeks, they can get the same effects that are noticed over a 6-month period using hearing aids. Hearing aids are sort of doing this, but in a very passive way. Putting hearing aids in, I'm opening up the world. The training, what we're doing is we are getting people actively engaging in a task and getting rewarded for actually doing better. And who doesn't like a bit of a reward every so often? We've also along the way improved a number of our treatments. And one of these is the development of what we call 3D spatial masking. The red represents tinnitus heard somewhere in the individual's head. It's not always in the ears, sometimes it's in the center of the head. We can recreate a sound through headphones that is placed over top of the tinnitus activity. So what we do is we manipulate sound, we place it over where it is heard in space, and when we do that, it is harder to separate the tinnitus sound from real world sound. Because when it's in your head, most of the sounds that we hear are in and around us, right? We separate sounds not only on hearing the differences in pitch, but we also use our ears to localize where a sound is. So if a person's talking here and a person's talking here, I can easily separate them and determine who I want to listen to. If they're together, it's harder to separate that out. From a brain perspective, if the brain cannot hear the tinnitus, it's not going to attend to it. Right? So that's one way we can improve tinnitus. The other way is through the training. So we're training people to listen to sounds again in different places, different pitches. It might be a bird, it might be a guitar, it might be a drill. And they have to identify what the sound is and where is that sound. And when we do that, we get results that are unlike anything that we have done before. When we combine all these approaches, some counselling to tell people what tinnitus is, to remove some of the anxiety, this 3D masking to effectively cover the tinnitus, and then training to train the individual not to attend to their tinnitus. When we do that, as I say, we get results bigger than anything that we have ourselves done in our lab. Changes bigger than the drug trials that we've done, larger than the hearing aid trials, and so on. Internationally, when we look at a lot of new innovative products that are being marketed around the world, this particular one here, these 3 lines here, and the length of the line represents how much of an effect. Was it a small effect, just a little change, a medium change, or a big change? These are from a therapy that's been launched in the United States last year, very successful. This is our prototype therapy here, and you can see the length of the bar is longer. which is great. Now that has enabled us, well, and also these are the various news organisations that carried a press release. We did a university press release. We thought, oh, we should let our colleagues know a little bit about our work. You know, that's how we sort of get attention. And we were somewhat surprised the next day, then we started getting emails in Spanish. And I was like, what's going on here? And then there were emails from different countries, Brazil, Spain, United States, and international media had picked up on this work. That's helpful because it does bring in investor interest. And we've formed a company, which Sue mentioned, True Silence, which is developing further tinnitus treatments. It's an American company, but the research group is based here in Auckland and is a spin out of the University of Auckland. We'll be launching this therapy in New Zealand in the next couple of months. We're currently getting FDA approval in the United States and setting up the networks that we need before launching in the United States next year. It consists of a clinician software in which they do various tests. They then upload that information onto the user's smartphone, and then that sends the information through to speakers or ear-level open earbuds, or through to the user's hearing aids if they happen to be hearing aid users. The software incorporates those things I've mentioned around 3D spatial masking and also auditory training, but in a much more commercial, slick manner than what we did have in our prototype. And we're undergoing further trials of this as we speak. This here is something that we use to pitch to investors where we're looking for them to support our company. And this represents the product. This represents, if you like, my career. When I started out, I wasn't driving this career towards a product, but it happens that, as I mentioned, a little bit of luck and some imagination drives you in different directions. And the AMRF has been involved in a number of these different pieces of work. And sometimes when looked at isolation, they look like little pieces of work. But when you actually put them together, they begin to amass and you see a story, a consistent story that provides the momentum to enable us to bring a product to market or to undertake larger, big studies that require a large amount of investment. Now, I'm almost there, but I want to tempt you with a couple of things before I talk about a little bit about the funding situation in New Zealand. We're not satisfied where we are. I talked about the brain recordings, and we have a number of PhD projects beginning soon, and hopefully that will be coming online should we get funding to enable us to use our training and the product that we have, but make it smarter so it can actually learn what the person should be doing based on brainwave activity. So if the brainwaves change in a way that is negative, the treatment reacts to that. If it's going in a positive direction, it reinforces that. If it plateaus, it looks at the brain activity and says, what should I do next? All automatically. There are a number of things that have to happen before that. One is people don't want to walk down the street wearing what looks like a bathing cap with wires attached to that. So we're shrinking that. We've gone from 64 down to 8. All right, we're going to try and reduce that even further, and wonderful people in engineering and at the different universities around Auckland are contributing to that. Another thing that we can do is we can tap into the visual aspect of the brain and use virtual reality. And so we have a number of projects in which people can move around an environment and explore their tinnitus and interacting with it. For example, here we've got these radios. They can, in the virtual environment, they can reach out, pick up a radio and move it around their head and put it where they would like to represent their tinnitus or interrupt the tinnitus.
So how can you learn more about these new developments and how they might help you? So my suggestion would be to contact your local audiologist and ask about what therapies are involved, and or look out for true silence on the internet. So a person with tinnitus will experience it in a very different way from another person with tinnitus. For some people, it's about the sound itself. For other people, it'll be around the reactions to that. For some people, there are particular parts of the brain that we can identify and target with different therapies. Understanding that and being able to identify the causes and factors involved in an individual's tinnitus is really important for future treatments. And the True Silence Q-Core tinnitus treatment is very much focused on these individual factors and creating a prescribed therapy for the individual. So when undertaken according to the prescription, should result in significant improvements in quality of life and reduction in tinnitus.
The future is very important, right? Now, you know, we all benefit from the people that have taught us, right? It was wonderful that my Form 3 form teacher is here to hear this talk, right? All the people that have taught us different aspects, right? I mentioned Ron Goody, Peter Thorne, and so on. It's also the case that, you know, I'm in a situation seeing people through. But one of the great problems in New Zealand research generally is a lot of our young and emerging researchers are on fixed term contracts. It's a little bit of a roll of the dice whether next year they will have a position or not. I'm safe, I'm employed by the university. Great. But when we have a look at some of the research labs, these are the leaders of the pharmacological tinnitus lab in Otago, Paul Smith, Dirk de Ridder, a neurosurgeon based at Dunedin, again, tinnitus researcher myself. As young and sprightly as we are, right, we are getting older, and inevitably we need to think about, well, who's going to carry this mantle, right? Who's going to pick up the mantle for a world-leading New Zealand Tinnitus Incorporated? And there are people there. Zori Dobrije, a research fellow who is going from small project to small project, looking for their next opportunity to do research. Dunya, who has just finished her PhD for me, has begun early on in her career. She's looking for what she's going to do in January of next year. You know, and for us, and this is common to academics, we're forever thinking of where we're going to help our colleagues find the next money. So I'm talking about this talk with the AMRF. One of the great things that the AMRF does is it does support our young and emerging researchers through postdoctoral fellowships. One of the big gaps in New Zealand is we have PhD scholarships, and then we have the employed academics, and in this in-between space, it's very fluid. And people come in, and then they unfortunately leave because there aren't the opportunities to carry on. So here's my advertorial for the day, right? This talk is brought to you by AMRF. This is something that I think if you are looking to give donations, this is a very worthy cause to support our young and emerging researchers. So I'm going to end there. Thank you. Thank you to the AMRF. These are just a few of the faces of researchers in my lab who have come and gone and benefited from the sort of support that the AMRF provides through research grants. So thank you very much.
What an amazing presentation, and the research that is going on and the breakthroughs that are happening are just incredible. And if you know anybody that has tinnitus or suffers from tinnitus, you all know that it's such a debilitating disease, and currently there is no cure. But Grant and his team have come a very long way in developing treatments for tinnitus and other hearing disabilities. So thank you very much for joining us. Look, we really could not do what we do without your support, and we couldn't fund people like Grant Searchfield to do what he does without your help. So please, I would ask if you would think about giving a donation, and remember, every cent of every single donation goes directly into medical research. So if you would like to make a donation, please go to our website, www.medicalresearch.org.nz, and help to support amazing researchers and medical professionals like Professor Grant Searchfield. Thanks so much for joining us, and I hope to see you again soon.